For this PowerPoint lecture, we will discuss how to assess how well the fetus is growing and developing. Okay, there are several different modalities that can be used to assess the status of the fetus. One of the most common and more important advances in neonatal assessment is the use of an ultrasound. There are different ways that an ultrasound can be helpful in finding out how baby is doing. The modern ultrasound machine uses a high frequency sound wave. That's important to know. Ultrasound is sound waves to locate and visualize the organs and tissues. And these waves are well below the level of intensity that could damage the tissues. So that's why they like to use ultrasound, because it keeps mom and baby safe. They have new high resolution devices out that can dynamically be able to give the caregiver insight on what's going on with the fetus, the structures, the activity, intrauterine environment. It helps them know whether the fluid levels are appropriate. They can even give cross-sectional views of the fetus's organs and allow for a more detailed look at any possible anomalies, which are basically things that are not developing properly. There are also transvaginal ultrasounds instead of going, which is an invasive procedure. So instead of going on top of the skin on mommy's tummy, they will insert a wand into the vaginal canal, and this gives them the ability to assess the fetus during the first trimester when it is very small, and where it is actually positioned in the pelvis. And it makes the transabdominal approach a little more difficult since it is during the first trimester when the baby is smaller. The accurate determination of fetal age is vital and can be done using an ultrasound. There are specific methods used to determine the fetal age by measuring from the top of the baby's head, called the crown, all the way to its rump. And that measurement is only accurate up to 12 weeks gestation. And then a biparietal diameter, which is the diameter of the fetus's head. They can also do an abdominal circumference and a femur length. So when you see an ultrasound being performed by an ultrasound tech, you will see them taking these measurements. Combination of the size of the head circumference, as well as the abdominal circumference and the length of the baby's femur can give you a good estimate of how much the fetus weighs. Once gestational age and weight are determined, they can better determine if there is any problems with intrauterine growth, or if there is excessive growth, which is macrosomia. Because our ultrasounds have much better technology these days than they have in the past, they are able to recognize anomalies much more sooner than they were in the past. Ideally, any anomaly in which there is an anatomic change in a structure or that results in a functional change in an actual organ or organ system is detectable in utero with an ultrasound. And the diagnostic accuracy of ultrasound is detecting anomalies increases with gestational age. So the bigger the baby gets, the more accurate the ultrasound results are. On page 33, there is a table 2-1, and it lists all the clinical applications of an obstetrical ultrasound. All right, Doppler assessment of blood velocities. A Doppler can be used to measure the relative blood flow, as you should know. You may have seen it being used clinically at the bedside when maybe a nurse needed to get an IV, or they couldn't measure the blood pressure. It was maybe the patient was hypotensive, so they used a Doppler to check the pulse, to see if it was actually there. A Doppler can also be used if you have a really hard blood gas to get, if you've ever seen that before. But just like in those situations with adults, it can also be used to measure the relative blood flow through the umbilical, placental, and fetal vessels. With the Doppler being used in labor and delivery, the biggest use for that is to make sure that there is no compromise of the fetus, or to estimate the compromise. But the most beneficial use may be evident in predicting prenatal problems in high-risk pregnancies. It is also suggested that Doppler velocimetry can decrease the number of cesarean sections, neonatal complications, and length of stay in a NICU. Clinically, you will probably see this being used if they think that there is some type of cord abnormality, where maybe they think the cord is being compressed by the pelvis and the baby's not getting any blood flow, or if they think that there's some placental abnormality where the placenta is not attached anymore and they're trying to determine if there's blood flow there. So anytime you have any concerns regarding baby receiving blood from mom, or if you are suspecting that there is some type of blood loss, then a Doppler can determine if you have an increase or decrease in blood flow to a particular area. Now, in amniocentesis, you're probably already familiar with this term because we've talked about it already, but an amniocentesis is when you take a needle, and anything centesis, you take a needle and you puncture something. So an amniocentesis means you're going to take a needle and puncture the amniotic sac. When you are puncturing the amniotic sac, it is to expel some of the amniotic fluid so that you can test it. So an amniocentesis can be done before 15 weeks. We consider that an early amniocentesis. Most typically is done mid-trimester, between the second and third trimesters. And it really depends on what they are testing for. The mid-trimester amniocentesis is the most commonly performed and the oldest of all procedures for prenatal diagnosis. It is considered the gold standard to which other procedures are compared. They go on to talk about the length of the gauge of the needle and the length of the needle and all that. None of that is really important for you to know. Then they go on to talk about the complications. And complications of an amniocentesis include trauma, infection, and hemorrhaging, which is why most people opt not to have an amniocentesis. The major complication is that if not done properly, they can accidentally puncture the fetus. Not good. They can puncture the umbilical cord or even the placenta. But it could, if punctured, could lead to intrauterine hemorrhage and death. Amniocentesis is relatively safe, however, but complications do exist, and the rate's usually less than 1%. Once they get the amniotic fluid, there are several tests that can be performed on this fluid. And you need to know these tests. Your LS ratio, which we talked about, the lecithin sphingomyelin test in the previous chapter. The way that they do that LS ratio to determine the presence of, to determine how developed the type 2 cells are to produce that surfactant. In order for them to do that test, they have to have a amniocentesis performed so that they can get the fluid to see what it is. Alpha fetal protein is another test that they can perform. Another thing that they can test for, another thing that they can test for to determine the status of the fetus, so to speak. And we call it AFP. AFP is the main serum in the developing fetus. It normally peaks around the 12th, reading is fundamental, 12th week of gestation, and then gradually decreases. Whenever there is a break in fetal skin, and they give you examples that could break the fetal skin, like anencephaly, that means a not well-formed brain, meningomyocele spina bifida, where things are exposed. So the baby is in the amniotic fluid, and if their dermis is not intact from head to toe, and you have things that are open, then you can test that by seeing if the AFP is continually increasing past the 12th week. So AFP will leak from the exposed tissues into the amniotic fluid. So a high level of AFP, therefore, is a good sign of some type of neural tube defect. Down syndrome will cause low levels of AFP. So that is in contrast to what we were just talking about with the exposed skin. When they do the amniocentesis and check for the AFP levels, the low measurement of AFP may be useful in detecting that the baby has Down syndrome. Bilirubin level is another test that can be performed off of an amniocentesis, off of the amniotic fluid that is obtained. And the level of bilirubin in the amniotic fluid is an aid in detecting hemolytic diseases, such as RH incompatibility. We talked about this last chapter, chapter 1, where if mom is not compatible to, if mom's RH factor is not compatible to baby's RH factor, that they will give mom RhoGAM to make sure that her next baby, that she does not, the antibodies do not try to fight that baby off when it is forming and developing. Well, it can happen in utero for the first baby. The antibodies start to build, and they could start to try to fight off the fetus because the RH factors are different, and a bilirubin level performed off of the amniotic fluid could help them to determine whether this is actually going on. So if there's an increase in amniotic bilirubin levels, that is proportionate to the degree of hemolysis that is occurring. So basically, the body is trying to kill off the baby's blood cells. Creatinine levels can be tested off of the amniotic fluid, and as pregnancy progresses, creatinine levels should increase. And in the presence of normal maternal levels, amniotic creatinine levels are used to help determine fetal kidney maturity. So if they're thinking that something is going on with baby's kidneys, then they will do the creatinine level. The amniotic fluid can also be used to check for meconium. An amniocentesis can detect the presence of meconium in the amniotic fluid. Normally clear amniotic fluid becomes greenish when the meconium is present, as you know. And the last test listed here is cytologic examination of the cells. So they can take the amniotic fluid and check the cellular content to look for skin, amnion, and the tracheobronchial tree. These cells can be used to diagnose a variety of genetic and chromosomal disorders. So if mom is high risk for any type of chromosomal disorders, they will perform a cytologic exam of the cells. So they'll take the amniotic fluid, they will send it to the cytology department, and the med techs that work in that department will look at those cells intently to see what they can see. Karyotyping of the cells, which is just a particular type of test, can be used to detect Down syndrome and other trisomy disorders. Trisomy is a condition where it is a fatal condition, actually. Trisomy 13 is the worst. So trisomy is the condition, and then they'll have a level or a number associated with it. If you want to look up trisomy 13 and see pictures of what those infants and toddlers look like, they most of them don't even look human. Their eyes are positioned in weird places on their face. Their ears may be higher or lower than where ears normally go. Like, things just don't line up the way symmetrically like ours do. So that can be determined by looking at the cells that are in the amniotic fluid. Fetal heart rate monitoring is the next way to assess the fetal status, and this is very commonly done, and it is a big deal. The average heart rate in early gestation is about 140 beats a minute, dropping to an average of 120 beats per minute near term. And one important factor in managing the fetus is that the fetal heart rate and variability, which we'll talk about later, correlate with fetal well-being. So the cardiac status needs to be measured when they are assessing mom. They also need to assess the baby. So you're going to auscultate. You want to hear what's going on, or they will auscultate, and also utilize technology. There's other electronics that we can use to monitor how well the baby's cardiac status is. Because if that status changes, you need to act quickly to fix things. Monitoring the heart rate of the fetus has become so common that every labor room has a fetal heart monitor. It's just the most common thing that is done. They have them in EDs, and they have them all up and down labor and delivery. The major reason for this popularity is that adverse results of delivery have diminished since they started being sure to monitor baby's heart rate. So fetal heart rate monitoring can identify fetal distress that may be difficult to perceive otherwise. Mom may look good. Mom may not be able to express that she feels funny or anything. Everything could be fine. But as soon as you pop that monitor on them, baby could be bradycardic or tachycardic, and that bradycardia and tachycardia not be associated with anything in particular. We'll talk about variability later and how increasing and decreasing heart rates is not uncommon if there's other things going on at the same time. So it is well established that labor and delivery are very stressful to the infant, as we know, and for this reason, the fetal heart rate is usually monitored along with uterine contractions. That was that other thing that I said. As long as other things are going on, we expect the heart rate to respond, and contractions is one. Baby should respond to the fact that the womb that they're in is rejecting it. It's spazzing, it's saying get out. Baby should respond to that. They should. If they're not responding, that's an issue too. So the correlation between the fetal heart rate and uterine contractions is very important. And we'll talk about how to be mindful of that as we go along. So how do we monitor it? You have an external abdominal transducer. And as you know from hemodynamics, a transducer is something that transmits something from one place to another. So in this case, what you're transmitting is the movement of the heart, blood, and heart valves, the heart and heart valves as they move blood throughout the cardiovascular system. And then electrodes will be placed on the abdomen, which will pick up the electrical activity. So you got a transducer that's picking up the movement, and then you have the electrode that is picking up the electrical activity of the fetal heart. As you know, the heart is mechanical as well as electrical. It has electrical impulses as well as the mechanical aspect, so you need to be measuring both. And that's why we have the transducer and the electrode that is a part of the fetal heart rate monitor. Small spindle electrode on the fetal scalp is in addition to what you typically see, but more and more facilities are adding this to the fetal heart rate monitoring. Not that they don't have it, it's just not readily available on every single fetal heart rate monitor. And plus the equipment is more expensive, so you may have it at your disposal to attach to the monitor, but it's no different than, say, if you're drawing blood. Some facilities, they don't care if you use a butterfly needle on every single patient. And then there are other facilities where they keep them under lock and key, and you got to know the password in order to get the butterfly needles. So it really just depends on what your facility's budget is like, whether you will have access to the electrode that you actually put on the fetus's scalp. And you can see a picture of that in your book. You can see where the transducer is, and the electrode, as well as the spiral. That's a typo. It says spinal on your PowerPoint. It should say spiral electrode. Okay. Let me make sure that's all I need for that. The next slide, we will talk more about variability and monitoring bradycardia and tachycardia and decelerations. So we're going to move on now to fetal scalp pH assessment, and then we'll go back to the fetal heart rate when we get to the next slide. So with the fetal scalp pH, it is used as a secondary tool for fetal heart rate monitoring. It is indicated when the baseline variability is absent. So since they're mentioning variability, I'll just go ahead and explain to you what variability is. Variability is the idea that the heart rate should be going up and down. It should vary, but it should vary in reaction to something. So something, an episode occurred. Mom gets up and goes to the bathroom, or mom's laying in the bed and a contraction comes. So the up and down, or the movement of the heart rate, should vary. We expect that. A healthy awake fetus has a constantly changing heart rate, usually between 5 and 10 beats per minute, up or down from the baseline. The beat to beat variability will be reduced, of course, in the presence of anything that's going to depress the central nervous system. So if you give something to mom to calm her down, obviously it's going to calm down baby too. If the baby is hypoxic, lack of oxygen is, of course, will mean lack of oxygen to the heart muscle. If the heart muscle doesn't get oxygen, it's not going to have the ability to vary because it's not functioning properly. If the fetus is immature, baby is too preemie to respond. It can't respond to stress. If the baby is asleep, then believe it or not, fetuses sleep too. So if you are having a contraction, especially if it's a low grade contraction or a Braxton Hicks, the baby could actually sleep right through that. And I already mentioned sedatives, but even narcotics. If mom takes a narcotic or is given one for whatever reason, it too can affect the variability of the heart rate. All right, so back to our fetal scalp pH assessment that we use in conjunction with fetal heart rate monitoring. When baseline variability is absent, so you don't see that up and down movement of the heart rate, and the baby is decelerating late and then having decreased variability, but they have abnormal tracings on the fetal heart rate monitor. Those are all things that could say we need an additional assessment and we want to see what the pH is like. Then they will go and do the fetal scalp pH. And the way that they do it is they put the mom tell the mom to assume the position that we females are so familiar with. Put our legs up in the lithotomy position with the feet in the stirrups and all that good stuff. And that should bring the baby's scalp to view. And they simply, let me see if the book has a picture. Yeah, there is a picture of a mom, a patient in the lithotomy position. And when they get the pH, it is considered to show that the baby is asphyxiated if the pH is between 7.2 to 7.24. That is shows slight asphyxia. But a pH of less than 7.2 is severe asphyxia. So they want the pH to be above 7.25. If it is not, then baby may be in trouble. So the fetal scalp pH is useful only in the presence of abnormal fetal heart rate tracings, because a normal tracing indicates a healthy infant in most cases. So again, you do not use this in and of itself. You use this in conjunction with the fetal heart rate. Okay, now that we talked about how to monitor the fetal heart rate, we're going to now talk about how to determine if there are problems with the fetal heart rate that is being measured. So the baseline heart rate is determined by watching the rate tracing for at least 10 minutes. The normal range should be between 120 to 160 beats per minute. The normal fetal heart rate will vary between the high to low end, but smaller gestational fetuses will usually be closer to the high end. So the smaller the gestational number, then the higher the heart rate. Although rates of 120 to 160 are considered normal, each fetus must be assessed carefully. An increase or a decrease from that fetus's baseline of 20 to 30 beats per minute may be abnormal, even though they fall within the normal range of 120 to 160. We'll talk more about that when we get to bradycardia and tachycardia. So I mentioned earlier that variability is nothing but the understanding that with every single beat, the heart rate may go up and down. We talked about things that could cause that to happen on the previous slide. But we expect a variability between 5 to 10 beats per minute in reference to the baseline. So if the baby's baseline was 140, then anything between 130 and 150 would be considered normal for that baby. Therefore, if the heart rate were to drop for the scenario I just gave you to 120, even though 120 is normal, that is below the baseline. Actually, that would be 20 below. And it said a baseline heart rate of 20 to 30 may be abnormal. And in this case, it is. It is abnormal because it is not within a normal variability. So for this baby, even though 120 is still in the normal limits, if the scenario I gave you of a heart rate at 140 being baseline, if it drops to 120, that is a heart rate of 20, within that abnormal range of 20 to 30 beats per minute variability. So heart rate baseline is 140. If it drops to 120, although 120 is normal under normal circumstances, it is not normal for this fetus. Hopefully that makes sense to you. Leading into that, we're going to talk about bradycardia and tachycardia. Now, bradycardia is technically defined as a heart rate less than 100. But there is another caveat to that. Bradycardia can also be determined if the patient has a drop of 20 beats per minute from their baseline. So back to my earlier scenario, heart rate of 140 is considered baseline. If that heart rate drops to 118, that drop is greater than 20 from the baseline, and therefore, although 118 is not below 100, it is still considered bradycardia for this baby, for the scenario that I gave you. Most dangerous cause of fetal bradycardia is asphyxia, which is not good. Asphyxia means that you have deprived the body of oxygen. In these cases, oxygen administration to the mother may help reduce the severity of the asphyxia. There are also other causes of bradycardia, and they include congenital heart block, secondary to a congenital malformation. There could be maternal systemic lupus erythematosus going on. Maybe administration of paracervical blocks and beta blockers may have been given to the mother. And lastly, fetal hypothermia could cause bradycardia to ensue. As you know, when you experience hypothermia, um, you will not get any oxygen going to the tissues, or lack thereof going to the tissues. Whenever fetal bradycardia is present, the primary concern should be to rule out asphyxia as the cause, because it can be diagnosed by the use of scalp pH. And we've already talked about how to do the scalp pH and what the ranges are and when we should be concerned. Bradycardia seen during the second stage of labor is divided into end stage and terminal bradycardia. End stage bradycardia is accompanied by standard variability and a prior normal tracing. So that's how you define end stage bradycardia. So they had the variability from beat to beat, 5 to 10 beats a minute. And they had a normal tracing. A normal vaginal delivery can be expected in the presence of end-stage bradycardia. But in contrast, terminal bradycardia is accompanied by no variability, and delivery is performed in the quickest possible manner because it indicates fetal distress. Now, tachycardia, on the other hand, is when the heart rate, the fetal heart rate, is consistently above 160. I know the text says 180. MBRC uses 160. The most common cause is maternal fever. And a tachycardia can also be caused by fetal or maternal infection, fetal dysrhythmia, maternal dehydration, maternal anxiety, stimulation of the fetus, and asphyxia. Sympathomimetic drugs are used to stop the contractions. And an example of a simple sympathomimetic that you would use is ritodrine, salbutamol, and terbutaline. And terbutaline is the most common drug given in this situation. And parasympatholytics, such as atropine, may cause fetal tachycardia when administered to the mother. So be mindful of what meds mom has been given prior to delivery, because that can affect how well the fetus is doing in utero and also once it is born. Okay, accelerations and decelerations are last. Acceleration is when the fetal heart rate exceeds 160 beats per minute for less than 2 minutes. It is also called, the text just said that it's also called an acceleration, but I had already said that. Accelerations during labor are a good sign that the fetus is reacting to the contraction in a positive way. So we like to see accelerations. Acceleration is not a bad thing. I mean, it's a stressful environment. We should expect to see some spikes in utero during the labor process. Decelerations, however, is when the heart rate drops below 120, and if this occurs for less than 2 minutes. Decelerations, in contrast to accelerations, may either be threatening or could be nothing, could be harmless. It really just depends on the characteristics of the deceleration and the timing of the deceleration. That is very crucial. What was going on? Why did the deceleration happen? And what's going on when it's happening. Now, as listed here on your slide and in your book, there are 3 types of decelerations. Type 1 is considered normal, and it actually occurs when the head is being compressed as the baby is advancing in the birth canal. So with earlier type 1 decelerations, they follow uterine contractions in onset and duration. So the baby will decelerate as long as that contraction lasts. The heart rate may drop to 60 to 80 beats per minute during the contraction. That is totally acceptable. Rapidly returning to baseline following the contraction. And type 1 decelerations are caused by the compression of the fetal head against the cervix and are benign. The bradycardia is due to the parasympathetic response and is not indicative of hypoxia. So bradycardia will occur, but that's just because of the parasympathetic system being stimulated, which when that occurs, you have a slower rate. Okay, type 2 decelerations do not follow uterine contractions. This is called a late deceleration, and it has to do with the placenta. So type 2 decelerations occur 10 to 30 seconds following the onset of the contraction, and then the heart rate does not return to baseline until after the contraction is over. Now, with type 2 decelerations, even a small decrease of 10 to 20 beats per minute from baseline is suggestive of the baby having some problems. Type 2 decelerations are also secondary to uteral placental insufficiency during contractions, which will lead to fetal asphyxia. So during a contraction, what's going to happen is the vessels of the uterus and the placenta are going to be compressed because you have less space available over time. And if you've gone the full route, the full weeks of gestation, then you're going to run out of room. So this is more likely to occur the farther along you are. So as the hypoxia worsens, the decelerations last longer and the beat-to-beat variability is lost. Progression of the hypoxia causes the decelerations to begin sooner and last longer, and the heart rate dipping lower with each contraction. Now, type 3 decelerations are independent of uterine contraction, which is opposite of type 1. Type 1 goes closely with uterine contractions. Type 3 has no relation to the uterine contractions. They are random in their onset, random in duration, and they are random in severity. The cord may either be wrapped around the infant's neck or be pinched between the pelvis and the presenting body part. Type 3 decelerations may or may not be dangerous depending on the frequency and severity of each occurrence. Alleviation of cord compression is accomplished by turning the mother from side to side or by assuming a knee-chest position. And in emergency situations, the presenting body part may be elevated to try to prevent further cord compression. So all things that can be done to assess the fetal heart patterns, and not just the heart rate. We're not just looking at the number, how fast or slow it is, but we're comparing the other things that go along with fetal heart rate to give us that pattern. There are 4 ways that you can estimate when the baby is due. The first way is the Nagel's rule, and is the most common method for determining estimated delivery date. What you're going to do is you're going to subtract 3 months from the first day of the last menstrual cycle. And then you're going to add 7 days to that number. And then that will give you your estimated date of confinement, meaning when the baby is due, the delivery date. So an example of that would be that the first day of mom's last menstrual cycle was March 25th. If you subtract 3 months from that date, you will get December 25th. And then you're going to add 7 days to that, and you end up at January 1st. This is only as accurate as mom's depiction of when her last cycle occurred, and also if mom had regular cycles that, and regular meaning that they came every 28 days or so. The use of oral contraceptives or an irregular menstrual cycle reduces the accuracy of this method. So most commonly used, and this is typically what physicians are charting when they're trying to determine the initial due date, unless other factors permit them from using it. Okay, fundal height is also utilized, and the fundus is like the head of the uterus. It opens on the opposite end from where the cervix is located. It can be measured on the abdominal wall as it grows with the fetus. It is fairly reliable. The height is fairly reliable during the first and second trimesters, but unreliable during the last trimester. In order to determine what the height of the fundus is, you have to take a tape measure and put it on the abdomen, and you're going to measure the distance from the symphysis pubis, that's where the 2 pelvic bones come together in the center, to the top of the fundus, up near where the boobs meet, so to speak, where the top of the hump, the baby bump, ends. So from where your pelvic bones meets in your pubic area up to where the baby bump ends, which is usually near where the boobs begin. During the first 2 trimesters, gestational age correlates to the measurement in centimeters. So if the fundal height is 20 centimeters, then mom should be about 20 weeks along. Okay, quickening is the next way to estimate due date. It is the first sensation of fetal movement experienced by mom. It is generally between 16 to 22 weeks that mom will feel the fluttering, but on average occurs near week 20. Because of the large variations, quickening is at best only a very rough estimate of gestational age. Last but not least, you can use fetal heartbeat as an indicator of when baby is due. The fetal heartbeat can be heard as early as week 16, but is nearly always heard no later than week 20. So they use a Doppler to hear the heartbeat, and the heartbeat can be detected much earlier when they use a Doppler, as early as 8 weeks. We know that the actual pumping mechanism begins as early as 3 weeks, because we learned that earlier in this section. But again, the determination of fetal heartbeat is only a rough estimation of gestational age because every baby is different. Okay, now we're going to talk about the biophysical tests that are used to determine the well-being of the fetus. The first one is called the contraction test, or CST. The CST is used to determine the presence of uteroplacental insufficiency. One of the original forms of measuring fetal compromise. So CST test is commonly done. I actually had one done when I was pregnant with my son, since I was high risk due to age. But the CST detects the uteroplacental insufficiency by subjecting the fetus to stress. That's important to understand. You're going to stress the fetus out and then see how they respond. The stress is going to come from an interruption of maternal blood to the intervillous spaces during contraction. A positive CST is defined as more than 50% of contractions having late FHR decelerations. FHR, of course, you know, is fetal heart rate. So 50% of the contractions causes the baby's heart rate to decelerate. With a negative CST, no decelerations are seen after any contractions. In reality, most CST tests do not clearly fall into one of the above categories. So you may have a kid that has decelerations, but they don't have, it's not in relation to every other contraction or 50% of the contractions. For this reason, there are several other classifications that the skilled practitioner, which won't be a respiratory therapist because we don't deal with mom, we only deal with baby, but the nurse, so to speak, uses to interpret the results, such as reactive, non-reactive, or minimally reactive. And also equivocal. Contraindications to the performance of CST include placenta previa, previous vertical cesarean section. Oh, okay, one of those old C-sections. That's what that is, because vertical is from top of the head down, very long scar like back in the day. Previous uterine rupture, premature labor, premature rupture of the membranes or PROM, an incompetent cervix. So if that cervix is not dilating, you don't want to do a CST. A variation of the CST is the oxytocin contraction test, or the OCT. If spontaneous contractions are inadequate when the CST is done, the drug oxytocin is given through an intravenous line to start contractions. An alternative method is manual nipple stimulation, because that also can start contractions. So you got the CST test that can be performed by stressing the baby out, but you also have a test called the non-stress test. In a healthy fetus, the heart rate increases in association with fetal body movement. Therefore, a second test was developed in which the response of fetal heart rate to fetal movements is observed. This test is called the NST, or non-stress test. To classify NST results, a qualifying heart rate acceleration increases at least 15 minutes over baseline and lasts at least 15 seconds. So the heart rate is going to accelerate, and it's going to stay accelerated for at least 15 seconds. A normal reactive pattern shows at least 2 accelerations in conjunction with fetal movement over a 20-minute window. A non-reactive NST occurs when the fetal heart rate does not accelerate during fetal body movement over 2 20-minute periods. So what they do is they sit you in a room and they monitor the baby's heart rate and the baby's movement. They put a little probe on your tummy and see what the heart rate does when the baby moves about. And some have extended the time period up to 120 minutes before declaring a non-reactive test, just to make sure. So 40 minutes minimum, because over 2 20-minute periods, or up to 120 minutes. So a negative NST is often followed by a CST to evaluate the cause of the inactivity. Because if the baby is not active during a non-stress test, it could just be that baby just ain't moving around and is asleep, and they actually give you tell you to do things to kind of make sure baby is up, like drink orange juice, or do something to make sure baby is mobile when you get to your appointment with the NST. And then if the baby is not active enough, then they schedule you for a CST, where they're going to make you have some contractions and stress the baby out on purpose. A negative CST is often followed by negative NST is often followed by a CST to evaluate the cause of the inactivity. A fetus suffering from prolonged hypoxia, this is important, will have a positive CST, but a negative NST. Negative CST results in the presence of a negative NST indicates the problem is one of fetal sleep or maternal narcotic or sedative ingestion. So you've either given something for the baby to not respond, whether they're stressed out or not stressed out. Now, the NST is popular mainly because it is simple to perform, less time consuming than the CST. The patient has little discomfort, and there is little risk from induced contractions. So make sure you know the difference between an NST and a CST, and when the results are positive or negative. Okay, the next one is vibroacoustic stimulation. It's just another method of soliciting a fetal response in addition to the NST. It is used by the use of vibroacoustic stimulation. In this test, a buzzer is held near or against the maternal abdomen. The fetal heart rate is then monitored for accelerations. The healthy fetus responds to the acoustic stimulation with an acceleration of the heart rate. Failure of the heart rate to increase may indicate a compromised fetus, and further evaluation should be done. So when you're doing the NST and they have the little monitor on the abdomen to monitor movement, and a probe to monitor the heart rate while the baby is moving about, or even when the baby is not moving. You also have this little buzzer that every time you hear the baby move, you press the buzzer, and that buzzer sends vibrations through your tummy to the fetus and should cause their heart rate to accelerate. Monitoring fetal movement is another way to test the well-being of the fetus. It's probably the easiest means of fetal assessment. It serves as an indirect measurement of the central nervous system integrity and function. Movement can be monitored as simply as having the mother note movement, or as complex as observation with ultrasound over an extended time period. Jerky movement of the fetus has been detected as early as 7 weeks and reaches its greatest activity between 28 and 34 weeks. Movements decrease the closer you get to term due to increasing fetal size and decreasing amniotic fluid volume. The mother first senses fetal movement sometime between 16 and 20 weeks. The test is simple in that it only requires the mother to note the number of fetal movements that she feels during a certain period. So usually within an hour's time, going to count how often baby is moving. Less than 10 movements over an hour requires further testing due to the fact that the fetal inactivity is associated with fetal distress and often stillbirth. Okay, assessment of amniotic fluid. This can be performed by ultrasound, but it has long been appreciated that there is a link between the volume of amniotic fluid and how well the fetus is doing. This has been demonstrated over time, and scientists have done studies to indicate that adequate amniotic fluid volume relates to longer pregnancies and higher neonatal survival. Amniotic fluid volume measurements may offer clues to the presence of certain anomalies, such as esophageal atresia, diaphragmatic hernia. We talked about that earlier. Whenever the inner parts of the body are exposed, then the amniotic fluid will, when you test amniotic fluid, you'll be able to see at the cellular level that something's not right. Cardiac, intracranial, spinal, and ventral wall defects, and also urinary trace abnormalities. All that can be done by assessing the amniotic fluid volume. Okay, you can actually do a biophysical profile. And a biophysical profile uses information gained from 5 separate tests. And table 2-2 tells you what those 5 separate tests are. One is fetal breathing, the other one is fetal movement, fetal limb tone, and NST, reactive NST, and then amniotic fluid volume. So basically, you're taking some of those tests that we talked about earlier and clumping all of those results and getting a score. Once you get that score, that will determine how well baby is doing. So each area is scored 0 or 1, depending on the finding. And then they modified it to be 0, 1, or 2. And then the biophysical profile is possibly the best overall method of fetal risk determination. So looking at several factors and giving an overall score instead of just looking at one factor, they're saying is a better indication. They also found that the biophysical profile is actually superior to the 1 and 5 minute APGAR score once baby is born to determine whether there is fetal acidosis going on. In figure 2-7, it actually shows you that if you measure the CST and show that there are late decelerations, if you have accelerations in your NST, biophysical profile, or CST, if those accelerations disappear, or you have fetal breathing that stops in the biophysical profile, if fetal movement ceases or fetal tone is absent, all of those things could be indicative of hypoxia and or acidosis. So you have several different methods in which to determine that: the biophysical profile, fetal movement counting, the CST, and the NST. The next assessment is meconium presence in the amniotic fluid. We've talked about this already, but you know, meconium is just a thick, dark greenish stool found in the fetal intestines, and the passage of it, when baby has its first poop, it occurs about 40% of the time. In post-term fetuses, it's usually a good indicator that baby has been baking a little too long. And hey, what's too long for one infant may not be too long for another. So 42 weeks gestation is usually when you see meconium, but you can have a mom that's at 40-week gestation and has meconium. So what you need to remember, though, is for the MBRC exam, the scenario that they're going to give you, I guarantee you that the gestation is going to be at least 42 weeks if they want you to suspect meconium. Frequency drops to about 10% in a term infant and 3 to 5% in a preterm fetus. Because meconium is present, it could result in the fetus being asphyxiated, but its reliability as evidence of fetal distress is still debatable. We talked about in class how right now we are doing meconium aspiration, where we're attaching an ET tube and going in and intubating, and then immediately extubating, looking for the presence of meconium on the ET tube. If you see meconium present, then you go back down with a new meconium aspirator until you come out with the tube that is clear. In the future, the discussion is that we will no longer use meconium aspirators, and we will either elect to intubate that baby or not. Intubate and ventilate, I should say, that baby or not. One of the two. This unreliability of saying meconium present equals fetal distress, that is not always the case. So this unreliability is based on, this unreliability is based on the fact that low 5-minute APGAR scores are found in only 10% of meconium stained neonates. The presence of meconium in the amniotic fluid is determined by amniocentesis, amnioscopy, which basically is an ultrasound to look at the amniotic sac, or actually visualizing the amniotic sac vaginally, or is actually visualized when the amniotic sac ruptures. So in the fluid, they see poop once mom ruptures her sac. One theory of asphyxia-induced meconium passage is that fetal asphyxia causes relaxation of the fetal anal sphincter and increases peristalsis of the intestines. So that's a theory. It has not been proven. It's not fact. But some theorists say that the reason why meconium is even present is because the fetus is experiencing asphyxiation and their intestines relax, and therefore poop is present. The most severe results of meconium release is meconium aspiration syndrome, MAS, in which meconium is aspirated into the trachea and airways. MAS is treated by what we will talk about when we get to chapter 10. So meconium aspiration syndrome is what occurs or the condition that occurs if meconium is present and it actually gets in the airway. Doesn't always get in the airway. So MAS does not always occur when you see meconium present in the amniotic sac before baby is born, but it could occur if the baby aspirates it. All right, a couple more here. Chorionic villus sampling is another way to assess the baby. The chorionic villus sampling is the process of removing a small sample from the chorionic villus of the placenta because it contains fetal blood and tissues. The sample is then examined for the presence of chromosomal abnormalities. The sample can be done either transcervically, transvaginally, or transabdominally, depending on the location of the placenta. Most chorionic villus samplings are done between 9 and 12 weeks of gestation, and they're usually done because mom is considered high risk, and outside of that, if mom has some type of family history that could be concerning, otherwise they will not perform this procedure. Indications for the procedure include advanced maternal age, previous child with chromosomal abnormalities, or a parent carrier of a chromosomal condition. It is particularly suited for DNA analysis because the amount of DNA obtained is significantly larger than that typically obtained when you do an amniocentesis. And with the advent of high-resolution, real-time ultrasound and flexible catheters, the procedure carries a fetal loss rate of less than 1%. Prior to the advent of all of these high-tech things, just doing the chorionic villus sampling, there was a high risk that you lose that baby anyway. So lots of moms were saying, nah, I'd rather not. And that 1% is also similar to the rate at which you would lose a fetus if they did an amniocentesis, which that number used to be high as well until procedures and technology had advanced. Okay, chordocentesis is the in utero sampling of fetal umbilical cord blood. The base of the umbilical cord is located with ultrasound, and a 22 gauge needle is inserted through the abdomen into the uterus. Uterus is a muscle. Muscles don't like to have needles put in them. I'll just leave that there. Okay. The umbilical cord is punctured and blood samples are drawn into tuberculin syringes. You know what tuberculin syringes look like? Those are the little skinny ones that are used when you go and do your PPD test for tuberculosis. So really skinny syringes. The fetal blood samples are then checked for several fetal problems, including hemoglobinopathies, like sickle cell, coagulopathies, such as hemophilia, specific IgM antibodies to fetal infection, metabolic disorders, suspected congenital anomalies, oxygenation and acid-base status are also able to be tested. This technique has evolved to be an important part of the evaluation of fetal well-being, and when properly done, both fetal and maternal risk is 1% or less. But due to the fact that it is invasive, just like when they go and put in a central line and respiratory has to be at the bedside because any slight jerk of the hand, that procedure could end up with a pneumothorax in the chest cavity, right? So same thing with this chordocentesis. You have very, very small room for error. So that's why it says when done properly. Okay. Biochemical methods of assessment is next. And estriol is a metabolite of estrogen. It is secreted in high quantities by the placenta in the latter half of pregnancy. Adequate production of estriol depends on a properly functioning fetal liver and adrenal glands. Optimum levels of the estriol in maternal urine require a healthy fetus, a properly functioning placenta, and a healthy mother. With the growing development of the fetus, the production of estriol increases. With growth retardation, fetal distress, and placenta insufficiency, you will have a decrease in estriol production. So estriol passes from the placenta into the maternal blood and is excreted into the mother's urine. Determinations of maternal estriol levels can be made using blood or urine samples. The mother's urine is collected over a 24-hour period and analyzed for the quantity of estriol present. But they don't just do the urine samples. Both blood and urine samples must be taken several times a week to be effective. Fetal distress is indicated if there is a 50 to 60% decrease from the previous test, or if there is an ongoing decrease in several values. This test is becoming unpopular owing to the high number of false positives and the inconvenience of having to collect your pee for 24 hours because moms pee continually throughout the day, a gazillion times a day, especially when the baby is sitting on your bladder. And it's also inconvenient to have to come in for blood sampling and the difficulty in outpatient managing. So you have, in a practice, you have a bunch of moms that are pregnant, and having them come in and getting their blood drawn is not as, is going to be a time management issue. And so this is a test that, if it is used very infrequently. Another biochemical method of assessment, is HPL levels. So they could either test the estriol or the HPL levels. And either one of those are considered biochemical methods of assessment. So the second method will be to determine the human placental lactogen levels produced by the placenta and excreted into the maternal blood. HPL levels gradually increase until 37 weeks gestation, at which point the level remains the same or decreases slightly. So maternal serum levels are evaluated weekly with normal ranges near term of 5.4 to 7 micrograms per milliliter. Fetal compromise may be present if HPL levels fall below 4 micrograms per milliliter after 30 weeks gestation, because it should be increasing, not decreasing. As with estriol determination, HPL determination has become less popular in recent years, probably for the same reasons as mentioned earlier with estriol, having to have patients come in and getting their blood drawn on a regular basis. On an outpatient status can be a scheduling nightmare. All right, last but not least, magnetic resonance imaging. The arrival of MRI has opened up new avenues not previously available. So unlike a CAT scan, the MRI does not use radiation and therefore does not pose the risk of causing defects in the developing fetus. So an MRI is especially suited for distinguishing between soft tissue structures and function of the structure. The MRI is capable of creating sagittal, axial, coronal plane views of any part of the body. The sagittal view appears to be the most helpful in assessing fetal status in the prenatal period. MRI is indicated in those instances where ultrasonography is often insufficient, such as when you have placental and fetal abnormalities and the development of the fetal lungs and brain, if you need to measure that for whatever reason. It is important to know the factors that make a mom considered to fall under the category of a high-risk pregnancy. So, of course, there are several different factors, and they're all listed here. You can see a full table, table 2-3 in your textbook. But there are socioeconomic factors like low income, poor housing. The socioeconomic part really just kind of makes me cringe a little. They mention things about unwed status, especially if it's an adolescent, minority status, poor nutritional status. Now that I can see, poor nutritional status, but some of these other ones listed makes me a little mad on the inside. Anywho, demographic factors are things like maternal age under the age of 16, being obese or underweight before getting pregnant, height of less than 5 feet. That can affect your ability to carry the baby adequately, so they say. Familial history of inherited disorders are all demographic factors to consider. So if you already know that historically women in your family have certain issues when they get pregnant, then that makes you at high risk for that issue. Medical factors fall into 2 categories: obstetrical history and maternal history. We'll go into the maternal history a little more in depth because that's the part that is concerning for us as respiratory therapists. But the obstetrical history, they mention lots of things. This is not a complete list, but history of infertility can affect your ability to even conceive. Ectopic pregnancies in the past can affect your ability to conceive. Miscarriages, previous multiple gestations, having a previous stillborn or neonatal death. So, baby was born, but once the baby was born, they died shortly thereafter. Uterine cervical abnormality, high parity, meaning you have lots of children, like Octomom or what's the family? The Duggars. Yeah, too many, delivered too many children. So that puts you high risk. History of premature labor or delivery, history of prolonged labor, if you've had a previous C-section, history of low birth weight infant, previous delivery of with mid forceps, they had to go in and yank the baby out. History of infant with malformations, birth injury, or neurologic deficit, or history of hydatidform mole or carcinoma. Hydatidform. Yeah, that word. Okay. Maternal medical history, as I mentioned, we're going to go into that a little more in depth on the next slide. But that is a list of things that once mom does get pregnant, the issues that can affect the fetus while they are growing and developing. Okay. And then current obstetric status, like what's going on with mom while she is currently being seen today. So absence of prenatal care, RH sensitization. Yes. As mentioned here on the slide, a Coombs test is used for blood incompatibility. They run this test to see if there is some RH sensitization. Yes, sensitization going on. See, I usually delete all this stuff, but I'm not deleting it today. So you're gonna hear all these screw ups that, as you have heard already in this video, I'm just over editing right now. Okay, so if you have RH sensitivity, so mom's RH factor is different from baby's RH factor. They can find that out by doing the Coombs test, and if the results are elevated, they're going to treat mom with Rogam. Going to give that injection of Rogam to mom after she has delivered that first baby. So if other things to consider excessively large or small fetus, premature labor, preeclampsia, that's when you have high blood pressure, because you are experiencing vascular constriction, multiple gestations, polyhydramnios, that's many too much amniotic fluid, that's what it is. And oligohydramnios, I think that's when you have low levels of amniotic fluid. Premature rupture of the membranes, vaginal bleeding, placenta previa, abrupto placenta, abnormal presentation, post-maturity, abnormalities in tests for fetal well-being, and maternal anemia. Last but not least are habits. Bad habits mom may have, like smoking, regular alcohol intake, drug use and abuse. All of those put mom in a category of being at high risk if mom tells the truth and lets the doctor know that she is doing those things, which most of them will lie. Okay, on the other slide I mentioned, we'll talk more about common maternal history concerns. Age is a very big one. Too old or too young are high risk. So less than 16 years of age puts you at risk for things like preeclampsia, low birth weight, and cephalopelvic disproportion. Baby's head is bigger than your little bitty pelvis. And that's a problem, right? 40-year years of age or older is at risk for preeclampsia, C-section, congenital anomalies, and chromosomal aberrations. And in more recent years, now they're putting 35 and older in that category, but definitely greater than 40 years is considered high risk. Prenatal care is another issue. No history of prenatal care puts you at high risk. And then there are nutrition slash diabetes concerns. If mom is malnutritioned, then the baby obviously will be malnutritioned and therefore may have low brain development. If mom develops maternal diabetes, then it puts them at high risk for preeclampsia. I already mentioned that means maternal hypertension. You could also end up with hypo or hyperglycemia. And what's most commonly seen, especially on MBRC exams, is that if you have a mom who has gestational diabetes, also maternal diabetes, same thing, the infant may be large for their gestational age, and we call that LGA because of the diabetes. So these babies are usually big babies. And then infants of diabetic moms, IDMs, are at risk of macrosomia, hypoglycemia, congenital anomalies, and respiratory distress syndrome. So maternal diabetes is different than someone who is a diabetic and then they get pregnant versus someone who is not diabetic and now all of a sudden, since they got this fetus in their womb, now they develop diabetes, which then goes away once baby is born. So that's different. IDM is mom is diabetic prior to getting pregnant, and now they have an infant involved in this scenario. So that's why there is a difference between maternal diabetes and IDM. Okay, last thing we're going to mention here about the maternal history, go into a little more in depthness about smoking and substance abuse. Nicotine or excessive caffeine intake may decrease blood supply to the fetus because, as you know, they are vasoconstrictors, and that will cause the baby to present with low birth weight. Alcoholics, women who drink during pregnancy, baby will end up with fetal alcohol syndrome or FAS, and developmental retardation, possibly. Drug addiction, risk of congenital anomalies, low birth weight, drug withdrawals, and low bilirubin levels are all things that are seen when mom was on some type of drug during the pregnancy. And then maternal infection. These two are very important and may be seen on the MBRC exam. Transplacental or congenital infections. We call them congenital infections because whenever baby gets something from mom, that's considered congenital. So through DNA or what have you, or even with it crossing through the placenta. So microbes circulating in maternal blood will then circulate and get into the fetus. And so whatever infection mom has that is considered transplacental, so does baby. And then perinatal. So the baby going through the womb, now that it's not protected by the amniotic sac anymore, any types of surface infections, herpes is a big one, that the baby is exposed to through the birth canal, the baby can get. And beta strep is the most common perinatal infection. Very important to remember. Beta strep is the most common maternal infection that an fetus can obtain perinatally. Okay, that ends our discussion on chapter 2, which is assessing the fetus's growth and development.